بحب اتكلم طبعا في كلينيكال اكزامينشن لان دي الحاجات البيزك اللي احنا بنتكلم عليها. فبنقول لكم السلام عليكم ورحمه الله وبركاته، ونبتدي بالكلينيكال هيب اكزامينشن. ما فيش حد في اي شهاده من الشهادات هيقدر يدخل going for exam except في long case or short case, but most of cases is long cases is a hip. Nobody ask any person must be examined on the hip. So the hip is very important. So how to examine the patient? It is systemic approach. If you are following the steps, step ladder, like history, listen and touch and think, obtaining imaging study, then interpret it, and then you will reach to the correct diagnosis, and then you will achieve the best treatment. But if you're missing one of these steps, this systemic approach will be failed and you will fail in the final diagnosis. So avoid lack of systemic approach in your clinical practice. This is my advice. Develop your own routine that work for you, but don't stray far from the normal. Just it is important to don't jump around and get the order of the hip examination out of sensitizing. It is not what you do, but how you do it. That is the count. Don't forget the 5 P's. This is circulation, and we'll speak about. This is very important. There's a few important points before you examine the patient. Introduce yourself to the patient, and then this means that you will take a consent, then expose the patient. And if you have a female, you have to have a female attending with you during the exam. And the professional attitude is you have to be polite, gesture, and good dressed, and handling and mobile in vibration mode. So this is a symptom of any complaint in the hip. The hip complaint is either pain, patient coming with a pain, swelling, deformity, limbing, or stiffness, or the loss of the function, or snapping, hearing some sound, or limb length discrepancy. This is the chief complaint of any patient coming to you for a hip problem. So in the history, the chief complaint you have to ask about the duration of the onset, progression of the symptom, and what is the various etiology related to the various etiology. Constitution and symptoms, very important. Comorbidity and habit of this patient. Treatment was taken or not. Occupation and recreation demanding and effect on the daily activity for this patient. The pain, which this is the first symptoms, you have to ask about 12 point, duration, onset, progression, is it constant, what localization, severity, the character, radiation, aggravating and relieving factor, what is the relation to it is a daily or night, and associated symptoms. So the pain, it is very important to know where the localization. This is the site. Is it anterior hip pain like arthritis, hip flexion strain, iliopsoas bursitis? It is in the lateral part of the hip, lateral hip pain, like in the greater trochanter bursitis, gluteal medius, tear, iliotibial band syndrome, or in the posterior hip pain, differential diagnosis like hip extensor and external rotator pathology. But don't forget, you have a referral pain, which is coming from referring pain to the knee or can be, and don't forget articular pain. If the patient coming with a swelling or stiffness, the site, the onset, the duration associated with pain or not, progression over the time for this swelling or stiffness. And what about the progression? Is it stationary? Is it increasing or it is regressing? So if the patient is coming with limb, you have to ask about the onset of the limb when it is started. What is how long is the duration associated with pain or not? This limbing, progressive or not? Ambulatory state, is the patient walking alone or with aid? The progression of the limbing, this is can be graded as the limb with aid. This patient needed something like aid, or limb without aid, or wheelchair the patient, and or come with bedridden. This is the degree of limb. What the deformity is present? How did it is starting? How is it is progressing? Any associated symptom? Is it there is any history of trauma or infection? What about limb lengthening discrepancy? You have to ask this patient how long it is present. Is it static or progressive? Associated symptom, any history of infection or tumor, trauma. The history to assess the functions. It is very important to ask about to assess this function of this patient, like walking ability, the normal or altered, this walking, or restricted or unrestricted. This patient can walk with aid or with unaid. If aid, which aid is used and which limb he uses, right hand or left hand. The ability to squat this patient, or the ability to sit across leg, and the ability to drive the car, and the ability to tie the shoes. This very important questions you have to give to assess the function of the hip joint. This is a very nice test. You can do it to exclude the hip problem. What about the past history? For this, you have to ask about trauma, history of tuberculosis, connective tissue disorder, steroid intake, surgical around the hip, skin or hematological disorder, any other significant medical and surgical illness, and lastly, about neurological disorder. About the personal history, ask about the diet, occupation, and working tolerance, smoking, alcoholic, sexual history, and the postmenopausal history. The family history is very, can give you some clue, like if the patient has a contact with a TB, close relative, or dysplasia in the family, metabolic disorder, or inflammatory arthritis. And at the end, we ask always you, what is the provisional diagnosis? So you have to give us this clue. Is it acute condition or chronic? It is progressive or non-progressive or regressive, monoarticular or polyarticular, and the possible etiology, put it in one of these etiology. Is it congenital? Is it traumatic? It is infective, inflammatory, neoplastic, degenerative, and metabolic. And at the end, you put that the patient demanding and expectation from the disease. Then the second part is a pattern of examination. This is the 5 pillars. You have to do an inspection, palpation, movement, measurement, and special test. We'll go through each one, and you have to be careful and examine in step by step. So the basic principle when you are doing prerequisite or examination, patient must be suitable and test. It's very important, and you have to have a hard bed. So like this way, it is not a suitable. By this way, it is not a suitable dress for the patient to be examined. And this is, you have to put the patient and examine in a suitable way. For general examination, you have to look from the head to the foot examination. Put it in your mind, examine from the top. This is what we call like body language. Look for the eye, like blue sclera, iritis. Look for the pen, low set or blackish discoloration. Look for the cheek, Miller rashes. For the mouth, normal dental and hairline, neck, nipple, shape of the chest wall, abdominal, protruding or not, nailing brittle, and the palm and whole, and hyperkeratosis, and also thickening of the lower end of the radius, malleoli, and the costochondrial junction, like metabolic bone disease. And also examine, ask about ligament laxity, like a position of the thumb to the flexor aspect of the forearm, passive extension of the finger, hyperextension of the elbow at least 10 degrees, hyperextension of the knee at least 10 degrees, excessive passive dorsiflexion of the ankle 45 degrees. If the patient has 3 of these 5, this means the patient has hyperlaxity. What about neurocutaneous markers? Very important, and general posture and attitude of the patient. This is what we call the general examination from the head to the foot. Then is an inspection. When we inspect the patient, you have to inspect the patient from standing, walking, sitting, and laying down. Look for from the front, side, and the back. This is very important when you inspect the patient. Look for any asymmetry when comparing to the normal side. So an inspection for standing position, inspected, this is very important. laying down. When inspected in the standing position, look for the gait, look for the alignment and limb lengthening discrepancy. What about laying down position? Look for the limb lengthening discrepancy and altitude. We'll go with these one by one. So general inspection, observe the patient first in a standing position when he's coming to you. Stand with the patient facing to you, always looking to the patient face. Be prepared to support the patient and considering the patient as a whole. Consider if the patient look well, is breathless at rest, is jaundice, or the generalized feature of psoriasis or rheumatoid arthritis. In this picture, looking for the general clue. It's very important, this clue. Any walking frame, if the patient has a frame in his hand, special shoes or orthotic present, this may indicate that there is a leg discrepancy. Does the patient use a stick, and is it in the corrected hand? Ask the patient if they have a walking stick. Talk to the patient, explain what you are going to do for him, and you are going to examine him 360 degrees. General inspection, observe the patient from, as we mentioned before, front, the side, and the back. We have to mention this for you again. This is the front for the scar, perfect tilt, and the quadriceps wasting. From the side, lumbar lordosis, knee flexion, and the foot arches. And from the back, the abnormal sclerotic curvature, abnormal ferrule, and increasing in pelvic tilt. So remember, examine the patient, lateral, anterior, and posterior. This is the point you have to be put in your mind when you are looking for inspection. Look for the altitude from the anterior and lateral and posterior. Look for the deformity. Look for the bone contour. Look for the soft contouring, swelling, wasting, limb length discrepancy, and the skin over the joint. This, you have to put it, these 9 markers, and you put it in your mind. This is an example, anterior superior spine raising, and this is the increase from lumbar lordosis, and there is a postural deformities, and this is the pelvic tilt. So for inspection from the front, the 9 parameters we mentioned. Does the patient standing straight and upright? Is it standing comfortable? Is it standing symmetrical? Or the shoulder level? Check the level of anterior superior spine for abduction and abduction deformity. Is there leg length discrepancy? Is there a fixed deformity? Ask for block if the pelvis is not level to assess the function leg length discrepancy. This is the point we mentioned before. And this is another clue. Is there any deformity in the coronal plane, like adduction, abduction, contraction of the hip, any thigh or calf wasting? Is the patient taking walk equally through with both legs? This is altitude, and examine the gait. Looking at the feet, is the foot taking weight in plantigrade fashion, or is the ankle or the foot inverted or in equinus? And inspect the skin for scar, sinus, evidence of circulatory disturbance. So from anterior to go from proximal to distal, the level of anterior superior spine, the normal halo of the iliac fossa, inguinal office, widening of the perineum, femoral artery pulsation, abnormal fullness in the carpal triangular, contouring and the level of the greater trochanter contouring and bulky of the thigh muscle, looking for abnormal contouring and wasting and the scar discoloration and the swelling and sinus. So from proximal to down, this is an example of a child with leg discrepancy and exaggerated lumbar lordosis. And this is an example of the patient with shortening and abduction deformity. This is the pelvic obliquity. Look from the front. Look for the anterior superior spine and pelvic. If the patient has anterior superior spine depressed, this means that this patient has a fixed abduction deformity. If the patient has the anterior superior spine elevated like this patient has a fixed abduction deformity. So this patient has leg like here, and this patient leg is abduction. This is in abduction. So from the side, we mentioned about 9 points, increase in lumbar lordosis, or is the patient standing with a stoop? If there is a flexion contraction of the hip or the knee deformity in axial plane, Are there is any scar from the previous surgical in the hip or surgical or disease? Is there is bruising and the sinus or dressing? Also, look for the lumbar lordosis, exaggerated lumbar lordosis is very important. Also, the position and the bulk of the trochanter. The trochanter give you an idea. If excessive lateral prominence is seen in it is seen in subluxation and dislocation, but reduce the prominence of the greater trochanter seen in the protrusive acetobulbar. Scarring sinus or any abnormal prominence can be detected from the side. And this is an example and the landmark of a patient to examine and the muscle. And this is a bruising in the tip of the greater trochanter. And this is a swelling and over the greater trochanter. Also, an inspection from the side. Ask the patient, can you point where the pain is? It's very important. Use the index of the patient to point where the pain. Pointing to the groin is probably arising from the hip joint. Pointing to their back or buttock is suggesting the possible referred pain from the spine to the hip. But it's very important, the C sign. The patient can do this C sign. It's very important, and this indicates that the patient has painful hip, which is very specific sign for the hip disease. Don't forget this, what we call the C sign. And the inspection from the back, as we mentioned, the 9 point. Does the patient have a straight or scoliotic lumbar spine? And if it is compensated or not. Check for any gluteal muscle, buttock, wasting, looking at the popliteal fossa. You are assessing the forward flexion. Check the spine for symmetrical movement and the normal rhythm. This is an example from the back. This is the patient has an abnormal buttock. Changing in the posterior superior iliac spine and increase for gluteal fold. And you can see this patient has a multiple varicose vein, and this patient has a different in the side. So look for the scoliosis level of the posterior superior spine and the iliac crest, symmetry of the gluteal fold, wasting of the gluteal muscle, scar, sinus, or abnormal mass. In standing position, very important. This is the steps you ask the patient. Patient able to stand, yes or not? Yes, you will move for the next step. If the patient able to walk, yes or not, walk. So if this patient you can walk, then check for the gait. The gait we will go for it. It's very important to know the type of the gait, Trendelenburg, Anterior, wide leg, short leg, and high stepping gait. Patient able to squat or not, this is very important to exclude the hip pathology. And in standing position, also and spine, wasting, disuse atrophy, neurological deficit, swelling, the called absence of discolor, dislocation or lipoma, and then scar and the sinus, and also the level of lateral fold, like in the DDH. And especially observing the gait is very important, and this is to give you a clue about the pathology in the hip. Check for the hip and the pelvis area for the skin abrasion and abnormal swelling. So what is the gait? The gait is a symbol of the definition is the mode of walking. So the gait is the mode of walking, how the patient walk or how you are walking. The normal gait is rhythmical, bipedal, biphasic walking in which is the lumbar spine and hip and leg moving in unison. Limbic is the most common abnormality. Can be defined as any abnormality of the normal rhythmic biphasic walking. This is what we call the abnormal gait. This is so when you're looking for the gait, look for the two things. Look for the limb and look for the trunk. The relation between the limb and the trunk, this gives you a clue about the gait. This is an example of abnormal gait like intelligent Trendelenburg, short leg, drop leg, and we'll go for this. This is an example of abnormal gait. You will see it in the video.
And now, let's have a look at a few abnormal gaits. First up is equinus. Here we want you to notice how she tiptoes on her left foot. This is because she can't dorsiflex, and as a result, she can't strike the ground with her heel. Equinus is seen in cerebral palsy, tightness of the Achilles tendon, and limb length discrepancy, amongst others. And now for drop foot, otherwise known as the high steppage gait. Notice how she raises her right knee higher during the swing phase in comparison to the other knee. This occurs because paralysis of her foot and ankle dorsiflexors in this leg prevents her from clearing the ground properly, and so she compensates by excessively flexing the hip and knee to achieve this. This is seen in direct injury to the dorsiflexors and deep perineal.
So this is the type of the gait, the antalgic gait.
Antalgic gait. In antalgic gait, you can demonstrate that the patient doesn't want to spend time on one of their legs. They have an abnormally shortened stance phase on one of their steps. So in the current patient, you can tell that they don't want to spend time on their left leg. They spend most of their stance time on their right side. However, when you can see the
And what about waddling gait? The waddling gait is the body sway from the side to side on a wide base seen in the bilateral DDH and the pregnancy. You can see this is the waddling gait, how the patient is walking. The body is sway from the side to side on the wide base seen like in bilateral DDH. And what about Trendelenburg gait? You have to differentiate between compensated and uncompensated Trendelenburg gait. So Trendelenburg gait, you have two types, compensated and non-compensated. The patient lurches on the affected side and the pelvis drop on the sound side. This is an example of Trendelenburg gait.
Notice how in the gait, how whenever he loads his weight onto his left foot, his right hip drops down and towards the affected side. So in this case, we would be demonstrating a Trendelenburg positive sign. This patient has a positive Trendelenburg sign, meaning that their left hip abductors, such as the gluteus minimus and the gluteus medius, are not working properly.
What about short limb gait? This patient, if I have a short limb, when the affected limb becomes short, up and down movement of the half of the body. This is the patient have a short limb gait. What about circumduction gait? This is like in hemiplegic gait, in fixed abduction deformity, or in hemiparesis, the patient moves his limb while dragging his body along the limb on the semicircular fashion. The other one is the gluteus maximum gait. In paralysis of the gluteus maximum, the patient lurches backward during the stand phase. What about the quadriceps gait? This is due to weakness of the quadriceps. The quadriceps weakens body, collapsed, hence the trunk goes from anterior bending to the shift of the vertical vector anterior to the knee. The other one is a in-toeing gait. This is due to increase in anteversion angle. The patient walking with both feet turning inward, seen in the femoral anteversion. What about the out-toeing gait? This is the patient walking with both feet turning out, seen in the femoral retroversion, what we call sharp gait. So the inspection, you have to ask the patient to make in standing position to do a Trendelenburg test. We mentioned about Trendelenburg walking gait, but this is the Trendelenburg test to check about the hip abductor. The Trendelenburg test can be done from the front and from the back, and this is the way you measure, you're looking for the gluteal fold. You ask the patient to stand on the normal sound side and then an abnormal disease side. The method one is standing on the front of the patient and ask them to hold their hand out in the front and placing their hand in your hand for the balance. Ask a patient to stand in the normal gait. So the sound side thing, this is that means that the abductor is weak and cannot support the pelvis. And this is from the back. This is another way. You ask the patient to put the hand on the sound side thing, and this means that there is a weakening of the abductor. But what we have, what we call the true positive due to weakness of the abductor. The causes of this true positive, it can be divided into two types, either due to neuromuscular condition or mechanical condition. This is what we ask you during the exam. If a Trendelenburg test is positive for the main reason, either due to neuromuscular condition or due to mechanical condition. For the neuromuscular condition, it is subdivided into generalized neuromuscular disease or localized neuromuscular disease. And generalized motor weakness like spinal cord lesion or myelomyelitis. What about localized neurological due to affection, mainly affection of the gluteus, like gluteal muscle paralysis or weakness due to superior gluteal nerve injury, or superior gluteal nerve dysfunction due to secondary to the previous hip surgery, like after total hip or during hip exposure, or during polio or neuromuscular condition can be affected. So the positive Trendelenburg due to neurological cause can be generalized or localized. What about the mechanical positive Trendelenburg gait? This includes conditions that affecting the abductor muscle lever arm. Here it is affecting the lever arm. The abductor is okay, but the lever arm is changing. So this can be occur during osteoarthritis, short neck in Coxa-Vara like hip fracture, DDH valculum failure because there is no acetabulum, post-total hip exposure with failure of adequate repair of the abductor, like in trochanteric osteotomy, you are changing the lever arm and the pivot failure, and during the fracture neck of femur or intertrochanteric fracture, this is due to a mechanical, what we call the positive Trendelenburg gait. So you have another three categories: false positive, false negative, and false positive and false negative. What do we mean by false positive? False positive, this can be occur if you have a good gluteal, but you have an inhibitor factor. The gluteal inhibition due to the pain secondary to osteoarthritis or a vascular necrosis, or during injection of the gluteus can be affected these and give you a false positive. What about the false negative? You have a fixed pelvis, and when you stand, the pelvis cannot be dropped, like in case of ankylosing arthrodesis or ankylosing hip, able to maintain the abductor and no abduction function. What about the false positive and false negative response? Can be occur if the patient has a poor balance or lack of coordination or unable to understanding instruction. This can give you one false positive and false negative. So for the Trendelenburg gait, we have a true positive, we have a false positive, we have false negative, and false positive and false negative. For the true, we have neurological cause or due to mechanical cause. So in the patient in laying down, you are go either from the top to the bottom or from the bottom to the top. So for in the patient laying down position, look for the altitude in the bed, lumbar lordosis, antispherical spine, gluteal trochanter position, and prominence. And also for the perineum, widening of the perineum or lateralization contouring, like in bilateral DDH. And also the carpal triangular, as there is the fullness or scar or sinus. Look for the skin, like coloration, texture, the prominent veins, look for the thigh wasting and the patellar position to exclude the internal and external torsions. Look for the patient laying down, also the calf for the wasting malleoli at the level of the two malleoli and the direction of the malleoli to excluding any rotation. Look for the heel, the level of both heel to exclude the leg discrepancy and straight leg raising. Look for asymmetry, it's very important. Apparent deformity and the rotational alignment of the leg, this is from the patella, and apparent deformity from the position of the heel. Any obvious shortening position is affecting the leg and either leg shortening. For palpation now, we will go from inspection to the second part, which is the palpation. Palpated, you have two types, is a superficial palpation and then go for deep palpation. Superficial palpation for the skin temperature, skin condition, scar, sinus, tenderness, bony thickening, swelling, soft tissues, and medial malleolus, and how to feel the medial malleolus and the level of the direction, and then the heel level, is it equal or not? This is a point of how to feel palpation from anterior, lateral, posterior, and medial, and then pelvic tenderness, and we'll go for this point one by one. For palpation, confirming the inspection. Palpation, the aim is to confirm what you found in inspection, and increasing on that, looking for the temperature, tenderness, and telescoping. For the lordosis, do what we call the Thomas test for flexion deformity of the hip. Palpated anterior, very important, is the bony landmark, anterior spherical spine, iliac crest, greater trochanter, posterior spherical spine, and trochanteric versa. This is from the palpate, how to palpate. From the anterior, look for the temperature, anterior joint line tenderness, confirm the level of anterior spherical spine, feeling the resistance over the scarp triangular and the femoral pulsation, the vascular sign of nerve. This is the anterior joint tenderness. It is the mid-inguinal point, 2 centimeters below and the lateral to this point. The greater trochanter tenderness over the trochanter. The medial joint line, you can palpate it in just posterior to the adductor longus, and this is the femoral pulse as the mid-inguinal point. The retrotrochanteric tenderness is very important. Is the mid-intertrochanteric posterior to the trochanter. It's very important to exclude any pathology. Then palpate is the Thomas test, the test with the knee flexion deformity. And you can do it by making the other limb flexion of the other limb and make the lumbar, increasing lumbar lordosis, obliterating the lumbar lordosis. But sometimes you can find that this patient has an flexion deformity of the knee. It is very difficult to exclude which is the angle. Is it from the hip or from the knee? So this is the other way to examine. Take the patient to the edge of the coach and examine the patient like this to exclude the flexion deformity. And this is the Thomas test, that you are putting your hand and then flexing the other limb to obliterating the lumbar lordosis. Then measure the angle between the thigh and the coach. It's very important to make this limb, the affected limb, internal rotated, not external. External can give you a false negative. But if you make an internal rotation, this means that the flexion deformity will be lessened. This is a demo for the Thomas test. And there is some criticism for the Thomas test. Like in the painful condition, you cannot do it. Observe obese or heavy belting individual, bilateral fixed flexion deformity of the hip, and in the present ankylosing spondylitis. By this way, you examine the patient on the prone position and examine take the line parallel to the spine, and then the line from the affected side, and this is the angle of flexion deformity. Then palpate the anterior superior spine to looking for the deformity, adduction or abduction deformity. For how to feel it, we ask the people how to feel the anterior superior spine. It is the first bony prominent, or when you starting from the inguinal ligament, over the inguinal ligament from here, the first bony prominent, not from the iliac crest. It is always go from the inguinal ligament. So the first bony prominent from the inguinal ligament, this means the anterior superior spine. And then check for the level, is it in the same level or up or down. And then the greater trochanter, look for the position and the tenderness, anteroposterior and axial. Laterally, for the greater trochanter, level or post superior, inferior, as well as the anterior posterior direction. Surface, is it smooth or irregular, or it is thickened? Tenderness, both local and on thrust. Posterior, any mass, as we mentioned, for the global bony mass that moving with the femur, we suggest the bony tumor, posterior joint line tenderness, and then for the movement. Now with the movement, when you have the movement, you have for active and passive movement. It's very important this point that the range of motion depends on the age of the patient, the gender, female or male, and the race. Also, gender and women have a great range of movement. Elderly will have lesser range of motion. Asian population have a great range of movement. So you have to put it in your mind when you examine. So for the movement, you have to put in your mind, ask about the active and passive, and if it is passive, what is the range? And is it associated with pain or not? Is it there is muscle spasm or not? Is it crepitus or not? Or is it there is instability? So you put this when you are doing the passive movement of the joint. So the movement of the hip is flexion, extension, abduction, adduction, lateral external rotation, and medial, which means the internal rotation. The examination can be done by, this is the normal range, and it can be flexion, flexion 120, extension 10 degrees, abduction 40 degrees, adduction 40 degrees. This is when the leg is straight. But when they do internal rotation in flexion, can be done by 35 degrees, internal rotation in extension 30 degrees, external rotation in flexion 45 degrees, external rotation in extension is 40 degrees. And the patient can do some circumduction, but it is incomplete because of the position of the other leg. This is a very important point you have to note when you do and the movement. Is the range of the movement normal comparing to the other side? So using the genometer. Is it is restricted? If it is restricted, which movement is restricted? Is in flexion or extension? If restricted, what is the severity of restriction? The degree from different normal. Is the movement painless or painful? If the movement, during which movement and during which part of the arm the movement become painful? Is it limitation of the movement due to mechanical problem like a bony block or something, or causing or due to the pain and the spasm from the patient? Is the axis of the movement normal? It is normal axis or not? Like when you have a slipped capital femoral face, can the patient move but with external rotation? Or there is any exaggerated of the normal movement or not? So you have to put this in your mind when we're asking you about the movement of the part. This is an flexion, is a flexion active, and this is in the passive movement. And this is an abduction with the limb in full extension and the angle. And this is the extension of the hip and how you do an extension of the hip, 10 degrees. And this is the movement with the movement external rotation with the 90 degree. With 90 degrees, the flexion is 45. In full extension, it is 45 degrees. The internal rotation in full extension and with internal rotation. With flexion, internal rotation in 90 degrees, flexion is 45 degrees. Internal rotation in full extension is nearly 45 degrees. You can do with the hip pronation, and this is the vertical line, and the line of the thigh. This is the angle of rotation, internal or external, according to the position of the foot. And you can make the rotation of the hip with the patient sitting like this way, and the patient internal and external rotation, and you can measure the angle between the long axis of the thigh, long axis of the tibia leg, and the vertical line. This is the angle of rotation. Then we ask you about if the patient has flexion or has a flexion attitude, what is the muscle? So we'll go for the muscle one by one very rapidly. The main hip flexor is the iliopsoas and pectineus, and this is other muscle can be assessed, but the main flexor of the hip is the iliopsoas and the pectineus. What's the hip extensor? It is the gluteus maximus, biceps femori, semitendinosus, and semimembranosus. What is the hip abductor? Is the gluteus medius and gluteus minimus. This is the main hip abductor. What is the hip adductor? Adductor brevis, longus, and magnus. This is the main hip adductors. What is the internal rotator of the hip? The gluteus medius, gluteus minimus, and tensor fascia lata. This is the make the hip rotation. External rotation of the hip is the piriformis, superior and inferior gemmelli, obturator internus, obturator externus, and the quadratus femoris. This is the extensor, the external rotator of the hip. Then we will come for a test. This is a test for the hip. So for the hip, you have to classify it into test to assess the limb balancing discrepancy, test to test the stability, test to test for the deformity assessment, and test for the impingement, and test for the muscle contraction. You put this in your mind, you will not lose, and you are going in systematic approach. So we will go for the first one, to test to assess the limb length discrepancy. For the, we have what we call leg length discrepancy, and this is leg discrepancy. Is it true or false, or true or apparent? True leg lengthening will measure from the anterior spherical spine to the medial malleus. This the apparent lower limb lengthening, it is determined not with the patient's supine, measured from the umbilicus to the medial malleus. The apparent lengthening or apparent shortening, this is the way to measurement. So this is the link, go by step. Is it true or apparent leg lengthening? How to examine the leg shortening, either by block method or supine position. Block method to measure the height and until you have the level of the anterior spherical spine, and in the supine position. In the patient, if it's supine, where is the shortening? Is it femoral or tibial? This is what we call segmental shortening. So we'll go through it. And where in the femur? Is it supratrochanteric or infratrochanteric? And we'll go one by one, and this is the way. So the apparent lengthening or shortening. The prerequisite, the limb must be parallel, measured between the midline point. This midline point, they take one of these 3 points, either from the zip sternum, or from manubrium sterni, or from the umbilicus. This one of this point, you put it the marker, and then to the medial malleus in both sides. If there is difference, there is apparent lengthening or apparent shortening. This is an example how to make the apparent lengthening or apparent shortening. And this is the way to measure this is from the umbilicus. This is from the sternum, and the last one from the umbilicus. And then how to make it real or true lengthening or shortening. The pelvis must be square of the pelvis, and you go from the anterior spherical spine to the medial malleus. This is to measure in both sides. This is measure the true lengthening or true shortening. Measurement from the anterior spherical spine to the medial malleolus. This is true shortening, and this is apparent. The first one from the umbilical or zip sternum to the medial malleus, but the true from the anterior spherical spine to the medial malleus. How to feel the anterior spherical spine? The first bony prominent from the inguinal ligament. So the apparent shortening or lengthening can be due adduction, apparent shortening. If the patient has adduction, it will be there is an apparent shortening. If has an abduction, there is be apparent lengthening. Then we'll go for the measurement. We have a true shortening. Is this shortening? Is it for the limb? Is it at the leg level or at the side or the supratrochanteric? This is what we call segmental measurement of the limb lengthening. So we'll do what we call the Galeazzi test, Galeazzi sign or align test. This is a test to measurement the either it is tibial or femoral, where is the shortening, and this is the way to measurement a Galeazzi test. The prominent of one leg, the affected leg prominent, it means that this is a femoral. If the other leg, this is tibia. If the other leg is down, this means there is a shortening, femoral shortening. This is an example. This is has a femoral shortening, and this is the other way you can examine if it's the leg by the patient prone position and comparing the both heels. And this is the leg shortening of the tibia. The tibia is shortening. And this segmental. The segmental will go from the medial joint line, the knee, and the medial malleolus. This is the medial joint line to the medial malleolus to measure the tibia. Is it from the tibia? If it is not from the tibia, from the medial joint line to the tip of the greater trochanter. So it is an femoral shortening. This is the tibia, how to measure it. The patient from the medial joint line to the medial malleolus. And this is the femur from the greater trochanter to the joint line. So when you have this measurement equal to the other side, so this patient has a shortening which it can be supratrochanteric. This is the other type, it is infratrochanteric. For the supratrochanteric, we will do what we call Bryant triangular and Nelson lines. So it's very important, you have to be concentrated. How to make in the Bryant triangular. Bryant triangular, you measure that, you take 3 points. The first point, the tip of the greater trochanter, and the line parallel to the shaft of the femur, extending, and from the anterior superior spine, a line dropping down straight forward on the line. These 2 points here will be met in this point, and the line from anterior superior spine to the tip of the greater trochanter. This presenting a triangle. This triangle equal to both sides, there is no supratrochanteric shortening. But if this limb, which from the tip of the greater trochanter to the dropping perpendicular line to the anterior spine, this means that the patient has supratrochanteric shortening. What about this line from the anterior superior spine to the tip of the greater trochanter? This line, we ask many people about it, and they don't know. This, if it is short comparing to the other side, this patient has internal rotation deformity. If this limb is bigger than the other side, this patient has external rotation deformity. What about the Nelson line to exclude to how to detect the supratrochanteric shortening? This is the line from the anterior superior spine to the ischium. And this line has to be touching the tip of the greater trochanter. The other we ask the patient how to feel the ischium. So ask the patient to lay down and from the midline of the side go up until the first bony prominent. This is the ischium. This is the example of the Bryant triangle. It is from the anterior superior spine to the line, vertical line to the spine, to the couch, and the other line parallel from the tip of the greater trochanter. This this point is presenting with the line from the anterior superior spine to the greater trochanter. This is presenting the Bryant triangle, and this is the Nelson line from the anterior superior spine to the ischium tuberosity. We have another line to measure the supratrochanteric shortening. This is called the Shoemaker line. This is the line is going from the tip of the greater trochanter and extending to the anterior superior spine and extending forward. And the other line, it has to be passing over the umbilicus. If this go down to the umbilicus, there is a shortening, supratrochanteric shortening. There is another line called Chinese parallelogram lines. This is the line from the tip of the greater trochanter to the other side, and from the anterior superior spine in both sides. These two lines has to be parallel to each other. If there is any difference, increasing or changing in the tip of the greater trochanter, this line will not be parallel. So this is the shoemaker line and Chinese parallelogram lines. There is another line is called Morris bitrochanteric test. This is the test for a measure from the tip of the greater trochanter to the pubic symphysis on both sides. It has to be equal, but if there is supratrochanteric or disturbance in the neck shaft angle, there will be change, reduction in and reduce in the hip dislocation. There is what we call the Catheria line or Catheria lines. This is the line presented for adduction and abduction, and we'll measure, we'll see. This is the patient from the anterior cervical spine and perpendicular line on the midline. It has to be aligned 90 degrees. But if this patient has adduction deformity, this is an adduction deformity. When you move the limb in neutral position, the anterior cervical spine will raise up, and this will make a difference in this two lines, and the angle between this is the angle of adduction deformity or abduction deformity. So the measurement is a true shortening. The true shortening can be infratrochanteric due to malunion, fracture femur or tibia, and gross arrest from the polio, and trauma on infection sequelae. But the supratrochanteric, as we mentioned, is due to coxa versus slipped capital femoral epiphysis, malunion, like base of the fracture neck femur, congenital coxa arthritis, and dislocation. This can be due to leading to what we call supratrochanteric shortening. Then we have to measure the muscle bulk. It is very important, and this is the way. You take a fixed point from the knee, and you go for a same distance in both limb, and the measurement of the circumference, and if there is muscle wasting or not. Then the other test, now this is the test for assessment of limb length discrepancy. What about the now test for assessment of the deformity? Is it the deformity can be either due to deformity along sagittal plane, this is the flexion extension, and we mentioned about the Thomas test. What deformity along the mediolateral plane, what you call the coronal plane, this is adduction or abduction deformity. What about the rotational deformity? This is the external or internal rotational deformity due to internal torsion or external torsion. So deformity along the sagittal plane, the flexion deformity, this is, there will be exaggerated with lumbar dendrosis, and we can test it by Thomas test, and we mentioned it before. And this is a Thomas test, and how you can do it by flexing, obliterating the lumbar dendrosis, and measure the distance between the long axis of the side and the limb. Test for the deformity, and this is another one, is the Healy-Brown extension test. We mentioned that if I have a patient obese and the patient with a painful hip, and you can measure it by this way to if you cannot do an Thomas test. So the deformity along the coronal plane, so the pelvic tilt, this is what we call adduction or abduction deformity, is it fixed. The pelvic tilt, so if the patient has adduction, the lowering of the anterior cervical spine of the disease side. If I have an adduction, elevation of the anterior cervical spine of the disease side. Both of them has to be accompanied with lateral deviation of the spine as the patient has a scoliosis. But the scoliosis is different according to the pelvic tilt. This is the fixed adduction, the pelvic tilt. This is the way the patient, if have an ABD, patient cannot walk by this way. If he reduce the limb to this side, so the anterior cervical spine will go down, and the other side it look like an abdomen. The pelvic compensated by lowering the anterior cervical spine of the disease side. About ADD, adduction deformity, the pelvic tilt. This is the patient has the pelvic compensated by elevation of anterior superior spine of the disease side. The patient, this is the limb abducted, so it cannot walk like this. When you go and put the leg in the other side, it has elevated the anterior superior of the same side. So this is the coronal deformity, adduction deformity, anterior superior spine elevated, fixed adduction deformity. If anterior superior spine referred fixed, depressed, يبقى fixed adduction deformity. And this is the way to measure the anterior superior spine. If it is elevated in the disease side, this is adduction deformity. If it is down, this is means that this patient has ABD deformity. This is abduction deformity, fixed abduction and adduction deformity. And this is how to measure the deformity. How to measure the angle itself. The angle itself, it is being measured by this way. You have to make the anterior superior spine in the same level by moving the diseased limb, either in abduction or in adduction, the position which has been mentioned for. And this is the angle between the anterior superior spine and this is the line. So this line of the limb and the perpendicular line on the anterior superior spine. This angle, this is the angle of abduction deformity. What about the adduction deformity? This is the line from the representing the limb length, the limb axis, and the other limb which is representing the perpendicular line over the anterior superior spine. This is the angle. This is the angle of adduction deformity. This is the other way to measure the adduction or abduction by Catharier's method. This is make the anterior superior spine level and measure and make perpendicular line. Then this is the limb. Then moving the limb to make the anterior superior spine at the same level, parallel to each other. Then the angle between the two is the angle of adduction or abduction deformity. According to this is adduction deformity. What about abnormal fixed position? Here, rotational deformity. This is the deformity, external and anterior rotation of the deformity, and this can be measured by always remain revealed deformity by noting the direction of the anterior superior surface of the patella. By here, patella, if there is internal tibial torsion, this means that the patella is a squint line, and it is the patella facing inward, and the patella or the toes when the foot is held at the right angle to the leg. This is a test to examine for the internal and external rotation by the Gray's test. The exhibition position in the prone for anteversion. You rotate, you touch the greater trochanter and hold the foot and moving the leg internal and external until the greater trochanter become more prominent. Then the angle between the vertical axis of the leg and the vertical line. This is the angle of internal and external rotation according to the position of the foot. This is now we come for the third type, test of stability, and we mentioned it before, but we will go through it. This is the test of Trendelenburg test. Let's describe by Friedrich Trendelenburg about the patient position standing. Don't do it the hip with fixed adduction or abduction deformity. If the patient has fixed adduction, don't do it because there is a deformity and they give you a false negative. And the other stability test, this is a telescopic test, a piston or Dupuytren test. Palpating the position of the superior in the position and pushing over the knee, and you will feel that there is an abnormal movement of the greater trochanter. This is an example of telescopic test. You feel that the hip is moving. And there is a Orthopaedic test. It can be done up to 6 months in the neonatal examination of the DDH. Here you will feel a clunk, not hearing a click. This is the example of what we call Orthopaedic test. But if the child is come to you after 6 months, you do what we call Barlow test. The Barlow test, you will feel a clunk, not hearing a click. This is the difference between Barlow test because we're dislocated and reducing the head. What about the other test for stability? Given test, patient position, supine or lateral position, proceeding holding the femur with one hand, stabilizing the pelvis, adduct and the internal rotation of the hip. Look for the spasmodic contraction of the muscle, and this can be with any causes of infection or tuberculosis of the hip or with fibrous ankylosing. The other stability test, don't forget about sacroiliac joint. This is an anterior pelvic compression test. You make a pressure on the iliac crest, and the patient will feel a pain as the sacroiliac joint, or anterior pelvic compression test. The patient will express the pain if they have instability of the sacroiliac joint. And this is a pubic symphysis test. This can be done, or a Stanfield test. The patient asks the patient to raising the test and pressure down and dorsiflexion. This will elicit sacroiliac pain. This is fulcrum test is very important in the patient with the functional neck of femur. The test stress fracture of the shaft of the femur. You put your hand under the thigh and press on the distal end of the femur. The patient will express some pain. This means that there is a stress fracture of the femur. Now we'll come for the test of impingement. And this test of impingement, it excluded any impingement in the hip. This is a febrile or Patrick test. Febrile, this is represented the flexion, abduction, external rotation, extension test. The patient position supine, and the patient can press on the knee and fix the pelvis. The patient will express pain. If it is anterior, this patient that has anterior impingement. If it is posterior, express the pain. This is a sacroiliac joint. And this is another way to do this febrile test or Patrick test. So the pain in the posterior area, this is means that sacroiliac arthritis. Pain in the anterior, in the hip, this is mean arthritis. This is an example, demo for a Patrick test. And you must fix it the hip, or stabilizing the hip. A scoral test, it is a test of the patient supine, producing done by the movement of the hip in the arc, in the flexion, abduction, internal rotation. And this is the patient, there will be arthritis or a sublumbral tear. If there is a clicking, this means that the patient has a sublumbral tear. A Stanfield test, resistant straight leg ring test, we mentioned it before for the test for impingement. And the hyperextension test, the posterior impingement test, the hyperextension, abduction, external rotation, the patient position in the prone, and if there is catch, if there is a catching type of pain, then the test is positive. The other one, feeder flexion, abduction, internal rotation test, or anterior impingement test. The patient position supine, if there is catching type of pain, then the test is positive. McCarthy test, this is the patient position supine, and on the couch, if the patient complains of catching pain, the test is positive. This means that the patient has a hip impingement. The last one is a test for muscle contraction. This is a test for the piriformis test. اللي هي flexion, adduction, internal rotation test. The patient will express by pressing the pain. If there is a pain in the buttock or sciatic, then this test is positive for the piriformis syndrome compression. Upper test, this is for the iliotibial tract. We mentioned it before, and this is the lateral position of the affected leg. And if it is positive, there is an iliotibial tract contraction. Eyes test, this is the examination of the biflexion, yani fully observe the flexion of the hip. And this is the test is very important for excluding the rectus femoris contraction. And this is can be elicited by LS test. What about here Phillips test? This is a test for the gracilis muscles contraction, and it can be done by the full internal external rotation, and then flexes the knee. If the contraction, the patient will experience some pain. Thomas test we mentioned before about the flexion deformity of the iliopsoas. Test to assess the muscle contraction, the examination of the gait, and we mentioned look for as the trunk perfect and the swing of the contralateral to the hand. Remember, at the end, remember, examine of the opposite hip, knee, and the spine. It's very important. Examine for the sacroiliac joint, examine for the distal neurovascular deficit, and the rectal examination. Examination of the hip is incomplete without examination of the spine and the knee. This is the key to examine finding anterior superior spine at the same level, no adduction or abduction deformity. Apparent measurement, really measurement, it is the same. But if the anterior superior spine is raised, this means this patient has adduction deformity. If the anterior superior spine is lower, this patient has IBD deformity. There is apparent lengthening and lengthening. Neurological examination is very important. Don't leave the patient without neurological examination. For the muscle testing, test of muscle strength and test for sensation. This is the motor and sensation and reflex. Diagnosis, if at the end of the examination, you have to put the diagnosis, either anatomical diagnosis or pathological diagnosis. Anatomical diagnosis means that this patient has either synovitis, arthritis, coxavara, unstable hip, and closing of the hip. Or go for pathology, and I prefer to go for pathology. This condition is a traumatic, and you mentioned the cause, inflammatory, and you mentioned neoplastic infection or degenerative. And at the end, I thank you for listening, and I hope that I make it clear for you. Thank you.
Thank you so much, our beloved Professor Bahaa Kornah, for this very, very nice, informative and illustrative talk. بصراحة حضرتك ما سبتش حاجة يا أستاذنا دكتور بهاء بيه، يعني كل حاجة اتقالت بصراحة. ربنا يبارك في حضرتك.
الله يخليكم.
احنا شاكرين أفضل حضرتك وتشريف حضرتك في الكورس الجميل ده يا فندم.
الله يخليك. هو طبعا ما فيش حد ما بيمتحنش إلا لازم يمتحن على حالة إيه. وبعدين
بدون شك.
الاكزامينيشن ده مهم جدا، والناس كتير قوي بتقعد تتلخبط، فلازم تمشي سيستماتيك، وده اللي انا الغرض منه. وكان عندي افلام كتير عطيتها، بس لقيت ان الوقت طبعا هاخد اكتر من يعني وقت يعني، فانا اسف.
لا العفو، احنا تعبنا حضرتك في التوك ده بصراحه يا دكتور بهاء بيه. احنا شاكرين افضل حضرتك يا فندم. Any questions to Professor Bahaa? You are waiting for questions? يعني انا اعتقد ان هو مش هيكون في questions كتير، لان هو ما شاء الله يعني كل حاجه very obvious. هم كل الناس بصراحه بيشكروا حضرتك يا فندم. Thank you very very much sir. Your presentation is extremely helpful than any other presentations. ودكتوره امنه بتقول very fruitful session. God bless you Professor Bahaa. هو كله بيشكر حضرتك بصراحه على الدكتور محمد سليمان. Thank you Professor Bahaa.
الله يخليك.
يعني كل الكومنتس اللي جايه بتشكر حضرتك بصراحه، يعني كلها كومنتس شكر، ما فيش حاجه اكتر من كده بصراحه حضرتك يعني فيري فيري نايس توك، وتعبنا حضرتك فيه جدا يا فندم.
خليك محمد، احنا تحت
شاكرين جدا، لان احنا نشوف حضرتك ان شاء الله برضو في اكزامينيشنز، في اذر اكزامينيشنز، يعني حضرتك ما تحرمناش برضو يا
انا تحت
فندم.
امرك في اي حاجه منه، اي بتاعنا يعني عندي المجموعه كلها.
ربنا يبارك في سيادتك يا فندم، شاكرين افضل حضرتك يا فندم. احنا كده خلصنا الاكزامينيشن. هيبقى النكست